So hello everyone, welcome back to the series of lectures in cardiology. So today we'll be starting off with valvular heart diseases, and the first of which we'll be looking at is mitral stenosis. Okay, so to understand mitral stenosis we should be knowing the structure of the mitral valve. So the mitral valve, as you can see here, is a bicuspid valve. So it has a anterior leaflet. So it has an anterior leaflet and it has a posterior leaflet. The leaflets are held together by a ring-like structure. This is what we call as the annulus. So the mitral valve basically is the valve which is opening between the left atrium as well as the left ventricle. So the mitral valve is attached by these thread-like structures that we can see here. These thread-like structures are what we call as the chordae tendineae. The chordae tendineae then attach themselves to these finger-like projections, which are projections from the LV itself. These are what we call as the papillary muscle. So the papillary muscles can be classified as the medial as well as the lateral papillary muscle. Now why is it that we should be aware of the structure of the mitral valve well? Is because any disorder which affects any of the structures, so any pathology which affects the leaflets, affects the annulus, affects the chordae tendineae or the papillary muscle can cause a mitral regurgitation in any way. So that we will be looking at when we discuss with mitral regurgitation. Now coming to mitral stenosis, what is mitral stenosis? There is stenosis of the valve, or there is a decrease in the surface area of the valve. So once the valve becomes stenosed, there is a decrease in the orifice area as well. So the normal valve area is 4 to 6 centimeters square. In mitral stenosis, the area becomes less than 2 centimeters square. So this is what is the basic fundamental behind this mitral stenosis. So let us look at the etiology. The major causes of mitral stenosis are, the first and the most important etiology that you have to remember is rheumatic. So rheumatic etiology is the most important and the most common etiology for mitral stenosis. Followed by rheumatic, you have to remember congenital, which includes parachute mitral valve, and severe calcification. Severe calcification and MS can be associated with connective tissue disorders as well, like SLE and rheumatoid arthritis. Okay, so these are the most important causes for mitral stenosis. Now let us look at the hemodynamics of mitral stenosis. Okay. So this is basically a line diagram which shows the LA, the LV as well as the aorta, and here between the LA and the LV is your mitral valve. So what happens initially when there is stenosis between the LA and the LV? So what happens? So the blood cannot freely pass through from the LA to the LV. Whenever there is a stenosis, there is an impediment to the flow of blood from the LA to the LV. Okay. So when there is an impediment to the flow of blood from the LA to the LV, we know that the LV is underfilled. Yes, the LV is underfilled. So in mitral stenosis, the chamber which is least affected is the LV, because the LV itself is underfilled. Now since the LV is underfilled, what happens to the cardiac output over the course of time? The cardiac output decreases. The cardiac output is reduced. So what are the symptoms that this patient can present with? Symptoms that the patient can present with is fatigue because of low cardiac output. The patient can also present with syncope if the stenosis becomes very severe. Okay, so over the course of time, what happens? Over the course of time, because of stenosis, there will be a pressure gradient which is developing here. There is a pressure gradient which is developing between the LA and the LV. So over the course of time, the LA begins to stretch. The LA begins to stretch so as to accommodate the high pressure which is generated in the left atrium. So whenever there is an increased left atrial pressure, which is the vessel which is draining into the left atrium, it is nothing but the pulmonary veins. So this pulmonary venous pressure increases and there is a backward pressure which results in a increased pulmonary capillary wedge pressure. So let me repeat, over the course of time there is a pressure gradient that is generated because of the stenosis between the LA and the LV. So this left atrial pressure increases as a result of this. The left atrial pressure is transmitted to the pulmonary veins and there is an increase in the pulmonary capillary wedge pressure as well. Now once the pulmonary capillary wedge pressure also increases, what happens? There can be some amount of transitation of the fluid into the lungs. Right, so there can be some amount of development of pulmonary edema. And what does this result in? This results in dyspnea. So this results in dyspnea. Over the course of time, you can also understand that there can be pulmonary venous hypertension and later progressing to pulmonary artery hypertension as well. Now what happens? You can see that in chronic MS, the left atrium has enlarged significantly. So the left atrium has enlarged significantly. So there is increased left atrial pressure, there is increased pulmonary capillary wedge pressure. Yeah, there will be development of pulmonary hypertension as well. And there can be development of right ventricular hypertrophy and right atrial enlargement as well. So you can see that there can be development of both left and right atrial enlargement, which is called as biatrial enlargement. Now, atrial enlargement has its own course of consequences. What happens when the atria are enlarged? The myocytes stretch beyond their capacity. If the myocytes stretch beyond their capacity, it is going to predispose to atrial fibrillation. So how does the atrial fibrillation present? The atrial fibrillation results in palpitations. Okay. So this enlarged atrium causes excessive stretching of the myocytes and it causes electrical instability leading to atrial fibrillation. Alright. Second, there is an important structure which passes behind. When the atrium enlarges, the enlarged atrium can compress on the recurrent laryngeal nerve and causes hoarseness of voice. And this is what we call as the Ortner's syndrome. This is what we call as the Ortner's syndrome. Okay. Now, as we all know that there will be development of pulmonary hypertension and pulmonary edema, and also the capillaries in the lung are also under high pressure. So this can lead to rupture of the capillaries in the lung. So rupture of the capillaries in the lung results in what we call as the pulmonary apoplexy. Pulmonary apoplexy causes a very important symptom, which is the cardiac cause for hemoptysis. So pulmonary apoplexy results in hemoptysis or development of blood in the sputum. Okay. So this is about the hemodynamics and the pathophysiology of mitral stenosis for you. So initially the underfilled LV can cause symptoms of low cardiac output. They can have fatigue, they can have syncope in very severe mitral stenosis. Over the course of time, there is an increase in the left atrial pressure, which causes an increase in the pulmonary capillary wedge pressure, exudation of fluid and pulmonary edema, which causes dyspnea. The enlarged atrium can have its own consequences. There can be atrial fibrillation, there can be compression of the recurrent laryngeal nerve leading to hoarseness of voice, which is called the Ortner's syndrome, and you can have pulmonary apoplexy resulting in hemoptysis. Okay, so that's about the hemodynamics for you. Now let us look at the clinical features of mitral stenosis. So if you have understood the pathophysiology very well, now the explanation of all of these clinical features also becomes very simple. Now can we just recollect what are the symptoms they can have? They can have fatigue, they can have palpitations, they can have dyspnea. Okay. The palpitations will be an irregular palpitations. So sometimes when patients come to us, you can ask them whether you felt the palpitations regularly at regular intervals or irregularly. So they will be irregular palpitations because of atrial fibrillations. So let us look at the signs in the general physical examination. Because of the low cardiac output, they will have a flushed appearance which is called as the mitral facies. Right? So they will have a low cardiac output, because of which you can have a peculiar facies which is called as the mitral facies. What happens to the pulse in mitral stenosis? The pulse in mitral stenosis is usually normal. In very, very severe cases, the pulse can be reduced. What happens to the blood pressure? The blood pressure is usually normal. What happens to the jugular venous pressure? With the development of pulmonary hypertension, you can have signs of pulmonary hypertension, which is a giant A wave, or followed by a giant A wave. The next would be the development of tricuspid regurgitation. If there is development of tricuspid regurgitation because of this severe pulmonary hypertension, you can have a giant V wave. This is only in the later stages once there is a development of pulmonary hypertension. Okay, so that is about the JVP. Now let us move on to the palpation. Where is the apical impulse? Now the apical impulse is the lowermost and outermost definitive cardiac impulse. Always remember that the apical impulse occurs due to chamber enlargement, which can be because of right ventricular hypertrophy or left ventricular hypertrophy. Now in mitral stenosis, the very basic point is that will the LV hypertrophy? No, because there is a stenosis at the level of mitral valve. The LV is underfilled. So there will be no LV enlargement because the LV is underfilled. So what happens is that with course of time, because there is backward pressure, LA pressure, pulmonary pressure and right ventricular hypertrophy, so there can be right ventricular hypertrophy. In right ventricular hypertrophy, the apical impulse will be shifted to the left, or the apical impulse will be displaced to the left, because the enlarging RV pushes the apex to the right. The enlarging RV pushes the apex to the left side, right? So the apical impulse may be the normal apical impulse in the left fifth intercostal space. The apical impulse due to the RV will also be in the left fifth intercostal space, but slightly more laterally. So it is pushed or displaced to the left, or it's displaced more laterally. Okay, fine. Now, will you feel for a thrill? Now, if you go through the lecture on murmurs, you palpate for the thrill using the head of the metatarsals. So, will you get a thrill? Yes, you can get a thrill. And what type of thrill? You will get a diastolic thrill in the mitral area, which means that it is in general, diastolic murmurs are not graded, but yes, if it is found with a 3. In general, diastolic murmurs are not graded, but yes, you can find a 3. We look for palpable P2. Why? Because with the development of pulmonary hypertension, you can find a palpable second heart sound. And how do you palpate for the palpable second heart sound? You palpate it using your tips of your fingers in the left second intercostal space or your pulmonary area. So you will find a palpable P2. Then, will you look for a parasternal heave? Yes, you will find a parasternal heave. Now, how do you examine for the parasternal heave? You basically use your wrist at the left parasternal area with your wrist cocked up, and you look for the movement of the chest wall. So, parasternal heave can be because of left atrial enlargement as well as right ventricular enlargement. So in MS, you know that there is both left atrial enlargement and right ventricular enlargement. So you will definitely have a parasternal heave. And the parasternal heave due to right ventricular enlargement is synchronous with the apex. Right? You keep your hand in the parasternal area and you auscultate or you feel for the apex. If it is happening synchronously, then the parasternal heave is due to the enlargement of the right ventricle. If it is not synchronous, then it is due to enlargement of the left atrium. Okay. So that is about the palpation. Now let us come to the auscultation. On auscultation, what about the first heart sound? We have learned from the lecture on the heart sounds that the first heart sound will be loud. Right? The first heart sound will be loud. Okay. Now, what about the second heart sound? What about the second heart sound? With the development of pulmonary hypertension, there can be a narrow split. With the development of pulmonary hypertension, there can be a narrow split because P2 occurs early. Okay, fine. Now, will you find an S3 in MS? No. Usually, you do not find an S3 or S4 in mitral stenosis. What about the murmur? The murmur is a mid-diastolic murmur which is heard in the apex, which is heard in the mitral area. It is a rough rumbling murmur. We describe it as a rough rumbling murmur which is heard best with the bell of the stethoscope with the patient in the left lateral or supine position. Right? So these are the features of your mitral stenosis murmur. Okay. Now, how do you clinically assess whether the mitral stenosis is severe or not? So mitral stenosis is defined as severe when the valve area is less than 1 centimeter square. So there will be certain symptoms and certain clinical findings using which you can definitely say that this patient mostly has a severe mitral stenosis. So what is that? That depends upon this A2OS gap. Now we have learned, again I would like to emphasize on the lecture on heart sounds. There is a specific sound that we had learned which is the OS, which stands for the opening snap. Opening snap is basically seen due to opening of the mitral valve. The opening snap is a diastolic sound which occurs due to opening of the mitral valve. Opening of a stenosed mitral valve. A normal mitral valve will not cause an opening snap. So a stenosed mitral valve causes an opening snap. So generally when you auscultate the murmur, this is your S2, this is your S1. So you have a mid-diastolic murmur. You hear the second heart sound, followed by which you hear the opening snap. Then you hear the murmur which is a mid-diastolic murmur. And you can also have a gap followed by pre-systolic accentuation of the murmur. You can have the pre-systolic accentuation of the murmur, right? So, opening snap and pre-systolic accentuation are two very important other features which are seen with mitral stenosis. Apart from this, what are the other things that you can see? You can see the presence of a P2. So development of pulmonary hypertension in itself means that the mitral stenosis is very severe. That is common sense, right? Unless the mitral stenosis has been going on for a long time, there will be no pulmonary hypertension. So presence of P2, presence of mitral phases, presence of atrial fibrillation, all this means that the MS is going on for a long time and it is a severe MS. Also, the severity of the MS is determined by the length of the murmur. Remember, not the intensity. The severity of MS is determined by the length of the murmur. Okay. And what is the importance of the A2OS gap in identifying the clinical severity? Decreased A2OS gap means more severe is the MS. As the A2OS gap shortens, which means what? If you can just see here, let's show you two examples. Now somewhere here there is OS and MDM, and somewhere here you are seeing that OS and the murmur. Now in patient A and patient B you are seeing that what? The length of the murmur is more. And what happens to the gap here? The gap has reduced. So naturally the A2OS gap is less, which means that the length of the murmur is more, right? So this means that this patient is having a severe mitral stenosis. Okay. So that is about the clinical properties of MS. Now let us look at the investigations. So the first investigation, what you want to do? The first investigation that you would want to do is the ECG. Now let us look at what changes you can find in the ECG. Okay. So here can you see that there is a broadened P wave? You can see that there is a broadened P wave. Can you see here? So a normal P wave is less than 2.5 small boxes. So if there is a wide P wave, a P wave of more than 2.5 small boxes, this is what we call as the P mitral. So P mitral is basically a finding which is suggestive of left atrial enlargement. Apart from this, what are the other ECG changes that you would find? You can find an atrial fibrillation. With the development of atrial fibrillation, you can find signs of pulmonary hypertension. P pulmonale as well. P pulmonale means that the height of P wave is more than 2.5 small boxes. You can have P pulmonale as well with the development of pulmonary hypertension, but the characteristic ECG finding is your P mitral. Okay, fine. Now let us look at the chest X-ray. In the chest X-ray, what is evident here? You can see that there is straightening of the left heart border. So there is straightening of the left heart border. Right? Can you see that the tracheal shadow is here, and you can see that the trachea is splayed, right? So there is splaying of the trachea. Then you have the left atrial as well as the right atrial enlargement. So we have the left atrial as well as the right atrial enlargement, which is looking like the double bubble sign. Okay, so these are some of the most important X-ray findings that you should remember when it comes to mitral stenosis. Now, let us look at the echo. So this is your echo picture. What view is this? This is your parasternal long axis view or your plaques view. So you don't have to remember the views. All you have to see that it is labeled. This is your LA, LV, and this valve which is between the LA and LV is your mitral valve. Now can you see that there is the valve is like this, or this is your hockey stick appearance. This is your hockey stick appearance of mitral stenosis. And can you see that the LA is also quite enlarged, right? So hockey stick appearance is what is seen of the mitral valve is seen in mitral stenosis. Apart from that, what are the other uses of this 2D echo? What are the other uses of 2D echo? You can see the degree of enlargement. You can see left atrial enlargement. You can see right atrial enlargement. You can look for RV hypertrophy. You can look for the cardiac output. You can see if there is development of pulmonary hypertension, which with the measurement of the PASP, right? So this is how the echo is useful in the mitral valve analysis. Apart from that, you can find the grading or the severity of stenosis can also be found out using the echo. Now, let us move on to the treatment. Right? Let us move on to the treatment. Now, before we move on to the treatment, there's one thing that you have to notice here. So, MS can be graded, or most of the valvular heart diseases are graded in this way. You don't have to remember every detail. All that you have to understand is they are graded into 4 stages, which is A, B, C and D. A basically means that they are at risk of MS. There is mild valve doming during diastole, right? However, there are no hemodynamic consequences, there are no symptoms. They are at risk of development of MS. So, patients who have been having repeated rheumatic fever, who do not have evidence of valvulitis yet, there will be only mild doming in them. So this is stage A, at risk of MS. Stage B is progressive MS. So, there are rheumatic valve changes with commissural fusion. Mitral area, however, is still more than 1.5 centimeters square. Mitral area, however, is still more than 1.5 centimeters square. They do not have any hemodynamic consequences. They do not have any symptoms. Stage C is asymptomatic severe MS and stage D is symptomatic severe MS. So, stage C is when they have asymptomatic severe MS. Basically, on the echo, the mitral valve area is less than 1.5 centimeters square. They have severe left atrial enlargement and severe pulmonary hypertension. And this is your diastolic pressure half time, which basically means that wherever there is a pressure gradient, the time taken for the pressure to drop to half is what we call as the pressure half time. So the pressure half time is also increased more than 150. So these are all indications of severe MS. So they have already progressed to severe MS, but still they do not have any symptoms. So asymptomatic severe MS is your stage C and stage D is your symptomatic severe MS, where you have a mean mitral area of less than 1.5 centimeters square. All of the symptoms are also present, includes exercise intolerance and exertional dyspnea. Okay, so this is about the staging of mitral stenosis. Why it is important to know the staging of mitral stenosis is that using this we can decide on whether the patient needs treatment or not. Okay, fine. Now let us look at this flow chart. So if there is rheumatic mitral stenosis, we see that there is severe MS. If the patient already has severe MS, is either stage C or stage D, correct? Just now we had looked at that. So he is either stage C or stage D. Stage C means that he is asymptomatic and stage D means that he is symptomatic. So what are the conditions where you want to do a mitral valve repair? Either you can do a repair or you can do a replacement. And how do you decide on that? That we will look at. So either you do a repair or you do a replacement, right? So if he is in stage D, he is already symptomatic. You can do a repair if there is a pliable valve, there is no clot and the mitral regurgitation is of less than grade 2. Let us just understand this with the help of this diagram. So what is shown here? This is what is known as your mitral valve repair, which is not called as repair as such. The reason why we are saying this is because you do not have an external valve replacement. This is your balloon mitral valvotomy. So we know that the orifice of the mitral valve is reduced, right? Now if you insert a balloon, then you can perforate and you can cause expansion or the valve can open, right? So the valve can open up more. So this is the whole principle behind this balloon mitral valvotomy. So you can see here in this image A that first there is a cannula and a guide wire that is inserted. Then we do an atrial puncture. The interatrial septum is punctured. From the RA it goes to the LA and then reaches the mitral valve. On the guide wire you load the balloon and then you inflate the balloon here. So the mitral valve opens up. So this is your percutaneous balloon mitral valvotomy. But the catch here is that, can you do the mitral valvotomy in everyone? No. There should be no calcifications. Right? There should be no calcifications. If there is an associated mitral regurgitation, can you do a valvotomy? No, you cannot do a valvotomy if there is an associated mitral regurgitation. If there are calcifications, if the valve is very thick, you cannot do. That is the reason why we are saying here is that if there is a pliable valve, the valve is pliable, there are no clots. If there is a clot sitting on the mitral valve, can you do it? You cannot do. And the MR is less than grade 2, then you can do your balloon valvotomy. Okay. Now, in asymptomatic stage C patients, again if the valve is pliable, in no clot and the MR is less than grade 2, then you can still do your percutaneous balloon mitral valvotomy, right? If they have severe symptoms, or suppose you are doing a surgery for something else, then please go ahead and do a surgical procedure, or you just replace the valve. But if the valve is not pliable, again you will have to do a surgical valve replacement. Now, in progressive MS with valve more than 1.5 centimeter square, which is your stage B, So in stage B patients, when do you want to treat the patient? If the patient has exertional symptoms, you do a stress test, and during the stress test there is a significant MS, then you can go ahead and do a percutaneous balloon mitral valve. Okay, fine. Okay, so this is about mitral stenosis. Let us also just look at certain other aspects that you have to consider if there is atrial fibrillation or if there is a valve replacement. So if your mitral stenosis has atrial fibrillation or if the patient has a valve replacement, then the patient has to be on lifelong anticoagulants. Why? Because atrial fibrillation and the presence of a prosthetic mitral valve predisposes an individual to a procoagulant state, and they can develop emboli. They can develop thrombosis and emboli, and that is the reason why the patient should be on lifelong anticoagulation. And this type of atrial fibrillation that develops in a patient of mitral stenosis is what we call as the valvular atrial fibrillation. This is what we call as the valvular AF. Okay, so this is the other aspect about management of mitral stenosis. And which type of anticoagulant will you use in valvular AF? In valvular AF, there is no role of NOACs. Why there is no role of NOACs? NOACs are novel oral anticoagulants like your dabigatran, apixaban and so on. This is not used, apixaban, rivaroxaban. There is no role. So the only anticoagulant that we can use is your warfarin. Right? So the only anticoagulant that we can use is your warfarin. Okay. So that brings us to the end of our discussion on mitral stenosis. Thank you.